Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. We've got a great episode for you today. Our topic is AI for general radiography, and our guests are Zachary Carr, an imaging quality specialist at a large academic medical center in Ohio, and Lory Hines of Siemens Healthineers. Zach and Lory, thanks for being with us today.
Thank you. Nice to be here.
Thanks for having us. We're super excited to talk to you today.
Same here. So let's start with introduction. Zach, can you go first and tell us about your work in radiology?
Sure. So my current role at my institute is an imaging quality specialist, primarily for the diagnostic modality. So that essentially covers plain film, X-rays, and radiographs. It also deals a bit with fluoroscopic procedure like LPs, myelograms, small bowel follow-throughs, things like that. Non-interventional fluoroscopy. A little bit of bone density as well. My role is kind of expansive. I contribute to some like capital planning, give recommendations on types of equipment, software upgrades, additional functionality, like with systems, like we'll talk about with like AI and whatnot. I deal a lot with like image quality. I have a sort of a radiologist peer that we discuss different types of like protocols, upgrades, and just managing sort of like a lot of the technical aspect of like imaging, as well as sort of like operational, like process improvement type things as well. So I've been doing that for almost 3 years at my institution, but I've been a technologist for about 16 years. The majority of that's been in the multimodality role. So I do have a lot of experience in diagnostic, but also CT and MRI.
All right, very good. Lory, how about you?
Well, Brian, I work for Siemens Healthineers, as you said, and I am the U.S. product manager for our X-ray products. But I started out as a technologist also, and I've had quite a large career in it. I've been doing this for over 20 years now. Started with regular X-rays, moved on to CT, did some ultrasound, did some mammography, but I always come back to X-ray, and that's why I'm super excited to talk to you about all the advances we have today in X-ray.
All right, very good. Well, let's dive into it. So, anybody who's paid any attention to radiology in the last few years knows that AI is probably the hottest topic going. And most of the discussion around AI and radiology has focused on the advanced modalities like MRI and CT, but X-ray is really the bread and butter of medical imaging. Lory, can you talk a little bit about why you think AI is so important in the X-ray world?
Absolutely. I mean, think about it. What is your first go-to when somebody's not feeling well? You get an X-ray, right? So it is the first thing we do to eliminate other things. So number one, we're going to take an X-ray. But with that being said, the volume of X-rays isn't going down. It's only going up, and it has gone up 2.3% in just the last year. But a little thing we also need to take notice of is that X-ray tech vacancies has also gone up by 8.5% this year. So we're taking more X-rays with less technologists. So that's where AI can come in and really help our technologists with their workflow.
Zach, what kind of use cases do you see for AI in general radiography?
Yeah, the more I think about it, I feel like it's probably easier to answer like what part of like diagnostic radiology is AI not going to touch. I mean, when I love doing this thought experiment where you kind of like, you form a set of variables in your head and you kind of see how it plays out. And, we have, as I'm sure a lot of facilities do, they have a lot of issues with like incorrect orders, across all modalities, all facilities. And it's understandable, how is a primary care physician supposed to know which order they're supposed to use in not just diagnostic, but fluoroscopy, interventional, like nukes, mammo, MRI, CT. It's completely impossible. So I can see AI helping with the ordering process, like to start with, like the correct order, like the first time. That could be a start, which would improve our process because it wouldn't slow us down with so many incorrect orders, having to go back to the ordering physician to be like, hey, are you sure you didn't want this order? Or like, I think you need this order, not this order. That would save us time, manpower. When it comes to just like speeding up radiology in general, I mean, part of this is also going to be like reporting and the role of AI to potentially screen for like critical findings, like prior to radiologists viewing it, can streamline the process as well. And things like, recognizing like patient anatomy on the systems. Like one thing I'm like fingers crossed I hope to see in the next couple of years is, some sort of AI process that can help technologists rapidly choose better techniques. I contribute to the dose index registry, the ACR's dose index registry for DR projections. And one of the things you see a real varying of exposure techniques across all projections. And I can't imagine it would be too much out of the realm to get some sort of AI system to recognize patient anatomy in terms of like patient thickness, and understand the appropriate contrast range for that given projection, and then give the technologist an appropriate technical factor to sort of like hone in on like what is an appropriate exposure versus, having some options laid in front of them, but maybe technologists don't always choose the appropriate ones. So, I mean, gosh, I could probably talk about this for hours about what I think AI could do to radiology, but the more I think about it, the more excited I get that it's literally going to touch every aspect of diagnostic.
Yeah, it's such a big field. Now, Lory, do you see similar use cases? And it's interesting that we're talking here about how AI can help technologists, because so much of the discussion lately about AI has been around, well, what can it do for radiologists? Can it help them analyze images, and can it help them do reporting and things like that? But technologists need a lot of help too. I mean, is what Zach said, does that resonate with you as well?
Absolutely. I mean, think about it. You're a technologist, you're running around the room, right? And these AI features, one of them being our 3D camera, which can keep an eye on the patient at all times for you, can help you enable things like we talked about prior, like collimation, and possibly even our 3D camera can see the girth of the patient to properly center the patient and to actually help that workflow, right? To take the strain off the technologist who's on their feet every single day for sometimes 8 to 12 hours a day, right? Running around. So I do believe that AI can help with workflows to make them more efficient. And Zach really said a word that is very, very important: consistency. Consistency is not always consistent when it comes to humans. I do things a little different than Zach does. Zach does things a little different than I do, both as technologists. But having these AI features can help with consistency, to help with the results for the radiologist, right? So they don't look at things different.
Yeah. Now, Zach, you mentioned X-ray collimation, and let's dive into that a little more deeply. Can you talk about how important accurate collimation is, and what makes that a challenge for technologists?
Collimation is one of the fundamental aspects of proper radiography. And, like when I was training, my X-ray career, we still had CR cassettes. So you're always trained, use the appropriate size CR cassette for the body regions you're doing. If you're doing a chest, use a 14 by 17. If you're doing a hand, use an 8 by 10, so on and so forth. So collimation was sort of self-limiting. If you choose the correct CR plate, your collimation was going to be, within a good realm. Now we've moved to DR, and there's no such thing as an 8 by 10 anymore, unless you're in sort of like a pediatric NICU situation where maybe you do have a small plate. But even now, we have 17 by 17 cassettes at our facility. So, you know, I don't want to say it's laziness, but I think there is, a bit of, again, inconsistency with technologists when they do a hand on a 17 by 17. Are they collimating tightly to that body region? And a lot of times we see like the answer is no, unfortunately. So improper collimation can cause a lot of issues up front. One, and I think one that not a lot of technologists appreciate yet, is collimation's effect on exposure index and deviation index. Again, back to the dose index registry for the ACR, we're trying to get a national view of exposures across all views. Collimation is going to have a huge effect on what that exposure index is, and ultimately the deviation index is. So your trends over time of what your views are going to be displaying in terms of dose are going to go up, the more you have like wide open collimation. So if we want to get an accurate representation of what is a proper exposure, proper collimation is going to be very fundamental in that. On the image quality side, the more tissue you expose for any given projection, the more grayscale you're going to get, more, more contrast, or I should say the less contrast you're going to get on your body region, depending on what you're doing. If you have tight collimation on a lumbar spine, your contrast should be pretty adequate for what you're looking for. But if you have wide open collimation, you're going to get much more grayscale. You're going to get less contrast between bony regions and soft tissue regions. And depending on the positioning of the patient, that can really cause radiologists some headaches. So collimation can be understated. It's a fundamental of imaging basics and something that I feel like is becoming more overlooked by the general technologist population.
Yeah. Now, Lory, Siemens has a technology to automate this process of calculating collimation. Can you talk about that a little bit?
Absolutely. So we have something called autothorax collimation, which is enabled by our 3D camera. So autothorax collimation is for the chest x-ray, and it can be done with a PA, an AP, or a lateral view of your chest x-ray. And with that being said, it is the most common x-ray ever taken. Imagine being able to collimate more accurately to whatever your facility wants, either tight or a little not as tight collimation, the same between technologists. And like I said, it is the most common x-ray, so we do them the most in the day. And I know Zach will definitely agree with me. But imagine saving 28% of the time it takes to actually collimate. You're taking time off the exam, which not only helps with the workflow, but it helps your patient, right? Because your patient is getting more attention from the technologist because they're not paying that detail to having to collimate, because our autothorax collimation does that for you. So they're centered on their patient. Plus, if you're here having a chest x-ray, 98% of the time, it's not for a screening reason. It's because you don't feel well. So you're standing there, and we're being able to reduce some of that time where the patient is having to concentrate on holding their breath or standing still and doing other things. So we have autothorax collimation, which I think is just an amazing tool, not only for the technologists, but for patient care also.
Yeah, and what systems does autothorax collimation work on?
It works on our Isio Express system, and we've also filtered that down to our impact family. So it works on both of our systems because we feel that important to be able to offer it to every level of care.
Right. Now, Zach, have you worked with autothorax collimation, and how do you feel like it affects not only the technologist experience, but also the patient experience?
Yeah, I've used autothorax collimation, and I still remember the first day I actually saw it. We had the system installed at one of our facilities, and we hadn't yet had other application specialists come in to give us the rundown. But me being the curious person that I am, I started playing with the system. And the first time I did it, I was like, I kind of stood back. I'm like, did I just do what I think it did? And I had to like kind of look in the manual to be like, oh yeah, it is doing that. It is collimating for me. I was like, that's amazing, and like I immediately saw the benefit of it. Like, not only from image quality wise, but just as sort of that, that second hand, there's one thing to have a technologist that's got 5-6 years of experience doing chest x-rays. Most technologists after a couple months get the hang of collimating for chest x-rays. But even like an experienced technologist, sometimes maybe they're not too sure of themselves. They're going to leave that open just a little bit more just to prevent like clippage of anatomy. But to have like what I'm assuming is millions or billions of images processed and analyzed through an algorithm to say, yes, this isn't a perfect collimation for this patient is a nice sort of like second hand to say like, yeah, it's fine. Like what the collimation that we want will be appropriate for this patient. And ever since I've used it, and I almost rarely never use it, only on specific patients that maybe are like very unsteady, or maybe I want to like in a cart or something where I can't use the wall detector. But anytime I can use it, I do use it, and I recommend it to all the technologists that I work with to get comfortable using it because it does help.
So, Zach, can you tell us what do you need to do as a technologist to engage autothorax collimation? What does that involve?
I mean, you don't have to engage it at all if you set it up with your individual protocol steps. It's something you can have on as default. So once a protocol step is selected and you position your patient, the camera recognizes the patient and it collimates for you. It's as simple as a click of a button if you want to turn it on and off on the fly. So it can be set by default. You don't have to do anything, or you can just click a button and turn it on. It's very simple.
It sounds super easy. Lory, what other AI features does Siemens have that would improve technologists' workflow and maybe ultimately improve the patient experience?
We have something called virtual collimation. We have smart virtual ortho and auto long leg and auto spine collimation. With my favorite being virtual collimation. And once I finish answering this, I'm going to let Zach add to this too, as he's still working as a technologist. But as a technologist, you have to collimate, as we've talked about, which is so important. But if your patient moves, or if you feel like the patient, you might want to check that positioning again, you would have to run back into the room, fix it, look at it, and then go back out to take your exposure. But with our 3D camera and the capability of using what we call virtual collimation, it's as simple as using a smartphone. You've got your eye on the patient at all times, and say your patient does move a little bit and you have to change your collimation, you just use your fingers, open up the collimation, or close in the collimation and change it the way that you see fit to get the best exposure the first time. Remember, like I said before, it's all about consistency and getting the right image the first time. And I know, Zach, that you at your facility, you use this a lot. Can you add to this a little bit as a technologist on how you feel like it just enhances your tech's workflow?
Oh yeah, I mean, from just about every one of our facilities, we utilize a two technologist model per system, and in that aspect, I think the Isio and the Xperi in particular does very well as a dual technologist system. One technologist can focus solely on the patient positioning, comfort in that regard, and the technologist behind the workstation can operate the system entirely independent of the technologist in the room, including selecting the protocol, selecting the technique, selecting the detector, and adjusting the collimation via that digital collimation, or a cool feature called recall collimation, where you can just simply use the collimation used previously on another protocol step. So it takes that mental load off of the positioning technologist who may be busy with that patient, and allows that to be distributed to that secondary technologist who's then essentially the system technologist. And expanding on that idea, we are a teaching facility, so we have radiographic students that come through all of our facilities, and they're kind of feeling out the area. You know what I mean? They want that hand on their shoulder to guide them to do something, but a lot of times they don't want you standing right behind them. You don't want to make them nervous, or some want to get out there and do it by themselves, but they also need the reassurance of the technologist that what they are doing is correct. So that camera and that digital collimation lets the student go out, do their thing, and then the technologist has that final say. Was the student comes around before exposure, be like, we're going to open this a little bit, or we're going to close this a little bit, without moving the patient or moving any systems, or having that tech or the student run back into the room to adjust that collimation. So absolutely fantastic in both of those regards.
Yeah. Now, Zach, in radiology, in AI for radiologists, there was initially a lot of apprehension among radiologists, and they were worried that AI might take their jobs and that sort of thing. Were techs at your institution, were they a little bit afraid of AI at first? And then what was their reaction after they actually started using it?
I mean, I don't know if they were, I don't know. Well, I guess first thing, I don't know that they would consider that AI. I think some people have, they think AI is this, or think AI is the other thing. I don't think they realize that autothorax collimation is in fact AI. I think they just view it as a system function. So with that regard, they'd say they're a little bit apprehensive with the system function, because it does take some getting used to. It's something that's never been a thing in 120 plus years of radiography. So to all of a sudden have a system that not only has a camera, but then will collimate for you, which again is a fundamental, imaging basic, should have anybody step back and be like, is this thing doing what I think it's doing? And when the answer is like yes, then it's just a matter of teaching them and getting them to understand like what it's doing and how it's going to benefit them. So yeah, apprehension is definitely a thing with autothorax, but once you get that technologist comfortable and they see, oh yeah, this does work really well, this is one less thing I have to do, most of the time they do adopt it. Now, like with any technology, you're going to have people that resist it. It's honestly a mixed bag of like older technologists and younger technologists. Some older technologists were like, I love it. I never have to touch a collimator knob for chest x-ray ever again. And some newer techs are like, I don't like it because I need control. I think you're going to get that mixed bag, but I think overall, I think technologists appreciate the option at the least.
Yeah. Now, Lory, I understand that you've got a white paper that talks about some of the features on some of these AI features and some of the the research that kind of backs up their impact on technologist workflow. Can you talk about that a little bit?
Yeah, I'm actually really proud of it. There's a lot of AI features out there today, right? But we are the only vendor that I know of that has a white paper that proves that our AI features actually work. With that said, it's a multi-center around the world, including the US study that we did with different institutions. Basically, the results of it are 100%, and yes, I said 100% of technologists that we polled love virtual collimation. We found that autothorax collimation saves 28% of the time it does to do a normal chest x-ray. Also, our ortho exams, we talked about the smart virtual ortho and the auto long leg and auto spine, which if you know anything about doing an ortho exam like that, they're very time consuming. Meaning you before would have to mark the top of the spine, mark the end of the spine, and then calculate a bunch of things before taking the exam. But with our auto spine and auto long leg, you're saving between 63 and 79% of the time to actually do these exams, which once again allows the technologist to focus on the patient, not all the background stuff. And we have a one pager and to the white paper that shows you these facts that we can supply you with. It's a nice flyer that we put together. But and I know it's just, to me, I'm super proud that we could actually prove that these features work and they work well. We're not just throwing them at you. We wanted to make sure that they worked.
Great. And Zach, do these numbers kind of ring true to you and your experience with these tools?
Oh yeah, I mean, most of our facilities prior to getting the Xpree did the sort of like I call them like the fulcrum, like stitched image, like scoliosis and bone length exams, where, as Lory mentioned, you have to angle the tube, set the top parameter, angle the bottom tube to the bottom, set your bottom parameter, so on and so forth. So having experienced that and then going to the smart ortho and with digital collimation, um, it saves an incredible amount of time. And I think part of the white paper that Lori's alluding to was at one of our facilities where we had technologists do both because Xpree has the option to do both. So we said, okay, do this one with the tilt function. Now we're going to do the next one with the non-tilt function. And it was unanimous. At the end of the day, they're like, can we stop doing the tilt function now because it takes too long and we like the digital collimation one. So I have yet to meet anybody that doesn't like the smart ortho with the system and prefers the tilt method. I haven't experienced it.
Very good. Lory, what else can we look forward to seeing from Siemens in the kind of general radiography area for the rest of the year?
We have a lot of good things coming. Some things we just can't talk about yet because we do have to submit things to the FDA, but we have a lot coming down the pike. And I really look forward to seeing you, everybody, at RSNA with some great new features coming down the pike. So please come visit us. RSNA 2025. We're always there. We'd love to see you all. Zach always stops by because he likes to play with our new features too. So help yourself. Join us. We look forward to 2025.
It'll be here sooner than you think. All right. Well, I'd like to thank Zachary Carr and Lory Hines for being with us today. It's a great discussion. Really enjoyed it.
Thank you.
Thank you.
All right. Signing off for the Imaging Wire. My name is Brian Casey.